So I'm Alia Qureshi, a general and minimally invasive surgeon at Beth Israel Deaconess Leahy Health and at Harvard Medical School, and I'm here with Dr. Ralph A. Ralph, would you like to?
Ralph A. I'm a thoracic and esophageal surgeon working in Seattle, Washington, the Swedish health system.
And so we're here for the Trailblazer project, and I'm going to start off the discussion chatting with Dr. A with regards to how it was that you were drawn to Foregut surgery.
Well, it's an interesting story because when I finished residency, I was interested in lung surgery actually, and in the United States the best avenue for that was to do cardiothoracic.
Sure.
But in New York, where my wife and I had worked, she is a nurse in the intensive care unit, the cardiac surgeons were pretty much living in the hospital, and she said, well, if you want to go into cardiothoracic, why don't we just get divorced at the beginning of your fellowship instead of waiting till the end when everybody else did.
Good point.
So that didn't seem like a good plan. So a buddy of mine was in England, and I knew the thoracic training was really good in England. So I went there primarily for lung surgery, but the serendipity was they had a huge esophageal experience, and so I learned some principles of esophageal surgery that I hadn't learned in residency, and that was really the beginning of it.
I see. So then you did your training in the UK, and then what led you to come across Dr. Hill?
So I was in private practice in Seattle, working at a competitive hospital to his, and where he was working there was a mandatory retirement age at age 65. And he thought they would change the rules for him, but they didn't. So when he turned 65, he came to our shop, and I thought I could either fight him or join him, and it made a lot more sense to try to join him. So we went into practice together, and that's what began the relationship.
Excellent. And
I should point out, too, that one of the first things they asked me when I went to England, and they knew I was from Seattle, was whether I knew Dr. Hill. He was internationally very well known in esophageal circles.
Well, that's interesting for two reasons. First, I'd like to know when Dr. Hill came up with his Hill repair. It must have been controversial. How was it received? So you mentioned that he was well known in the UK, across many miles. How was he perceived here in the United States? Did you have a sense of that?
So in that era, or open surgery of course, any of the textbooks listed 3 operations by the time I'd started practice. One was the Nissen, of course. Second was the Belzy repair, and actually Belzy had worked at the hospital in England where I trained. He had retired, but his mentee was there, and that's where I learned to do the Belzy repair. And then the other was the Hill repair. So it was widely regarded, considered one of the legitimate anti-reflux operations. But he and Tom DeMeester had quite a number of battles on the stage, I think. So obviously the Nissen sort of won the battle.
Sure.
But I think he was well respected. When he first started doing his repair, he was one of the first surgeons to incorporate manometry. And his first presentations were very well received. There were a number of centers around the country that picked up on the Hill repair and considered it to be a superior repair. He was actually on the cover of Time magazine at one point for his work.
Oh, that's impressive.
It was. Yeah.
Not many surgeons make it to Time magazine.
Yeah.
And what was he like to work with? So you spent quite a few years with him, am I correct?
About 12 years, yeah.
Yeah. And so the Hill repair, could you elaborate on the components of the Hill repair, the important aspects to the surgical procedure in a brief?
Yeah, so one thing I loved about Luke was he saw the world through his own eyes. He's very bright, and he challenged others to look freshly at things. So he refused to accept the sort of common viewpoints that were sometimes groupthink. For example, the concept of the gastroesophageal valve had already been disproven. David Skinner had done some work in baboons, topping the top of the fundus off, and had shown the valve didn't really contribute. And Luke saw that clearly wasn't right, and so we've inherited his concept about the anatomy of the gastroesophageal valve because he did all the work in that area. And then his Hill repair was based on careful cadaver dissections, and he reasoned that the whole GE junction and GI tract are anchored posteriorly. And so he's got a cadaver dissection where the diaphragm was completely stripped away and the GE junction is firmly anchored by the posterior frontoesophageal membrane. So that was sort of the foundation for his repair. He put a lot of science into it in terms of studying the outcomes of the procedure.
So he clearly demonstrated that the gastroesophageal valve existed. and demonstrated that the fixation was very important.
Mm-hmm.
So why was it then, I'm going to be provocative and say then, why wasn't it so widely accepted amongst North American surgeons? As you said, the Nissen was much more held up. So why is that?
Well, there are two obvious reasons to me. One is that the heel repair is harder to understand.
Sure.
Anybody can look at a picture of a Nissen and understand it. It's pretty intuitive. With a heel repair, even looking at pictures, sometimes it's not so clear. And we kind of suspected that Luke didn't really want to teach it. He wanted everybody to send all the world's cases to him.
I see.
So that's number one. Number two is that the study that Tom DeMeester did back in the 70s when he was at Tripler was a randomized trial, Nissen, Hill, and Belzy. And the Nissen was the superior operation in that. We've looked at the results of the way that procedure was done. We always questioned whether it was really a heel repair. And then, of course, we replicated that study in the era of laparoscopy. Lee Swanstrom and I did a randomized trial, again comparing the laparoscopic heel and the Nissen. And we trained each other. He attended cases with me at Swedish for the Nissen, and I attended cases with him for the Hill. So we standardized the operations as much as possible. We randomized roughly 100 patients, and we showed that at 1 year they were equivalent, both objective and subjective outcomes. So I think they are probably equivalent repairs, both with strengths and weaknesses, but the damage had been done with that randomized trial that Tom DeMeester done. And then, to his credit, Dr. DeMeester did so many wonderful and important physiologic studies demonstrating the components of the Nissen fundoplication, popularizing it, teaching surgeons how to do it. And so the legacy is very much earned.
So then, as you just said, again being provocative, if they're equivalent in their performance, then why would a surgeon want to take on a more challenging operation? Right. I mean, that's kind of the logical question to ask.
Right.
If they are in fact equivalent, why do you want to learn something that's harder, and perhaps technically if you don't get it right, it's not going to perform well?
So I think the answer to that is durability. We know from a number of studies that the Nissen results, and it was discussed this morning on stage by some of the pioneers, that the Nissen results tend to deteriorate over time. I think there's something about the way the Hill sutures anchor the GE junction to the preaortic fascia that has more durability than Nissen. It is able to handle axial tension better. We have both an open study with over 1,000 patients and a laparoscopic study of 218 patients out in the 10 to 20 year range, both showing really remarkable results compared to anything else out there. So I think the legacy of the Hill repair may be in those Hill sutures themselves and anchoring the GE junction down, that there's some durability that can't be achieved with a Nissen fundoplication, which really, as we're taught to do it, is not an anchored repair. And if you think about it, the most common failure for a Nissen is that the whole wrap herniates into the mediastinum because it's not anchored. And as soon as we finish a Nissen repair, the intra-abdominal pressure forces that wrap up against the hiatus. So I'm hoping that the next generation will look at these Hill sutures objectively and study the potential for that to make a difference in terms of durability, because as surgeons, we need to be able to show that the operation works not just for 2 years, but for a lifetime. This is benign disease, and we need a solution that will last the patient the rest of their life.
No, absolutely. In terms of the operation, so you're an innovator, you're a trailblazer yourself, and I know you may not accept that, but I know that's true. So you innovated and came up with the Nissen-Hill hybrid. And in terms of that operation, what do you think that has to offer that maybe the Hill does not?
So that came out of our randomized trial, Hill versus Nissen. As I mentioned, the results were equivalent, but the recurrence the recurrence rates were equivalent, but the recurrence patterns were different. We saw that the Nissen, we had 2 out of roughly 50 Nissens that herniated in mediastinum and 2 out of roughly 50 Hills that loosened because there's a lot of stress on those anterior Hill sutures. And so it made sense to put the two together, and you were part of that, actually, our initial pilot study. And we studied initially paraesophageal hernia because of the high anatomic recurrence rate. And did a pilot study of 20, putting the two operations together, and then 50, using the Hill sutures to hold the esophagus down so the Nissen won't herniate, and then a full Nissen wrap above the Hill sutures so the Hill sutures won't loosen. So that was the concept behind it. And our study looking at 5-year follow-up for paraesophageal hernia repair showed a remarkable difference in recurrence rate between the Nissen alone in our group versus the combination, from 45% anatomic recurrence to 5%. So I think there's really something to that durability. We've looked at it for non-paraesophageals as well, and there's certainly in the data we looked at a trend toward lower recurrence rate. So I think that combination, the drawback to the Hill repair is that those Hill sutures act a little bit like aceton. There's a fair amount of stress on them, and what I mean by that is those sutures can gradually sort of pull through the tissue.
Yes.
So the Nissen provides some radial integrity that the Hill sometimes lacks.
Right.
Yeah.
No, and I know we've spoken about this, that the two are actually complementary and offset the negatives from each operation. So then, then my next question is, well, why has that not caught on? So I know you've demonstrated that is an excellent operation, has low recurrence rates. And I suspect it's going to become circular, that the issue is the Hill sutures. Is that correct, or is that not correct?
Yeah, I think we're sort of disappointed in the way we sort of group think in medicine in general.
Sure.
We like to do what we were taught to do because we know what the results are when we do that. Why hasn't it reached the critical threshold? There just aren't enough people out there talking about it. We don't have enough data showing that it's worth making the change and going through the learning curve. And as you say, I think people don't know what's a Hill suture. They don't really know what it's all
understand.
about.
Right. And I think your point about the fact that the visual conceptualization of the Hill, that's possibly its biggest challenge, because even when you show it to another surgeon, they don't quite get the arcuate ligament, that you're taking tissue of the right anterior. And I think maybe some thought around perhaps virtually recreating that for surgeons to understand conceptually. Maybe that may be part of it, but who knows. With regards to the Hill nowadays and bariatric surgery, I think there may be an opportunity again for the Hill to resurface. All of these patients that have gastric sleeves, for example, and then present with reflux, or in particular those patients that have reflux to begin with. Could you see a role for the Hill in that setting?
Absolutely, and I think some have looked at that, and there's been some interest in doing more of a prospective study looking at it. Certainly we see patients who have had a bariatric procedure, including a hiatal hernia repair, and then they're back 2 years later with the hernia having come back again, and the surgeon's only solution typically is to close the hiatus again. That's not really addressing the axial tension issues at all. So in terms of reestablishing intra-abdominal esophagus, the Hill would be great for that. The Hill, for that component, doesn't require any fundus to do it. So there's some real potential there. That's something I'd like to see studied more.
No, absolutely. What would you say is your, or perhaps Dr. Hill's, long-term or legacy after all the body of work? What would you say? And that might be a difficult question for you.
Well, the valve, the appearance of the valve and the grading system has been picked up internationally.
Sure.
It doesn't cost any money to do at the time you're doing an endoscopy, and it has predictive value in terms of how severe the reflux is. So, and it's also helpful in monitoring outcomes of procedures to assess the quality of the valve. So I think that's been one significant contribution. And then the second is the Hill sutures, in that, as I said, the durability of that fixation of the GE junction rather than the fundus to the preaortic fascia. And time will tell what happens with that. I hope that concept, again, is studied more. I hope that people will the next generation of surgeons will look into that, because I think we can do better than we're doing with the standard Nissen repair. So those would be, I think, the biggest legacies that Hill has offered. The Hill repair itself, I still do it. I don't do it as much as I did. You know, I don't think it's quite as sturdy as the hybrid repair. It probably has fewer side effects, and and we do have 25-year data with the laparoscopic repair. That's the largest, longest follow-up of any laparoscopic anti-reflux procedure out there. So if you looked at it as an academician, you'd say these are the best results out there. This is the repair we should be doing. But it's, as you say, if our randomized trial had shown superiority to the Hill, it'd be a little easier to say this is something everybody should be learning. But I think that's going to be a hard one to promote for the future.
Absolutely. Do you think that the Hill repair using intraoperative manometry is a barrier to surgeons? Do you think that might be part of the challenge of the Hill?
Yes, absolutely. It's one more step that adds time and adds technical requirements,
Challenge.
and that was certainly off-putting for a lot of people.
No, absolutely. And you still do intraoperative manometry when you do the Hill?
We do. There were a number of people who trained with Luke who did not do manometry and got good results, but we've got a pretty simple system that's not worth going into now, so it's not that much more to do. We hook it up to the arterial monitor by anesthesia, so it's pretty straightforward, but it's another learning curve.
No, and you know, one of the criticisms that I've heard about the Hill from other surgeons is that they can't get, or they can't reproduce the results that Dr. Hill was able to get. What would you say to those critics?
You have to learn the repair. In our multi-institution study with open surgery, we had 1,180 people at 5 centers around the country, and the results were actually better at the non-Hill centers than at Hill.
Right.
So we know that people that took the time to learn the operation and reproduced it, it works very well in anyone's hands.
Excellent. Well, that was an excellent explanation, and I appreciate the time, Dr. A, for today.
Thank you, Dr. Qureshi.
My pleasure.